This is the second PowerPoint presentation in this series called Head and Spinal Injury. We will be covering concepts related to spinal cord injury as well as the condition of autonomic dysreflexia. Damage to the spinal cord through crushing, bruising, or severing is permanent and irreversible. The millions of nerve fibers which make up the spinal cord cannot regenerate after injury. When the spinal cord is damaged, the messages to and from the brain cannot get through. So for many, a damaged spinal cord will mean permanent paralysis. This picture shows an example of a complete spinal cord injury. That means that the injury goes across the entire cross section of the spinal cord. From that point on, from the level of the injury, everything below it will have loss of movement and loss of sensation. So again, with a complete loss, a complete resection of the spinal cord due to any of those other causes, crushing, bruising, or severing, if it goes completely through the spinal cord, there's going to be loss of movement and sensation below the level of the injury. A loss of function is associated with each level of injury. Spinal cord injuries can be classified as either complete, as we saw in the previous slide, or incomplete. When an injury is called complete, it means that the feeling and control of movement below the point of injury are totally lost. In an incomplete injury, however, there may be some feeling and control of movement below the point of injury. The patient and the healthcare providers will not know the extent of injury, the extent of feeling and control of movement that will be present until some time has passed. We cannot predict the outcome of a spinal cord injury immediately when it is an incomplete injury. Sometimes we just have to wait and see what, after all the swelling and inflammation goes down, what feeling or sensation and what movement they are left with. The higher the point of injury, the more function that is lost to that individual. These are the areas of the spinal cord that we refer to: the cervical vertebrae and the cervical spine up here, the thoracic vertebrae, the lumbar, and the sacral. This is valuable because it shows you the nerve roots coming off of the spine. Remember, the nerves run in between the vertebrae, the bony vertebrae, and then they innervate various parts of the body. Down here, as we get lower, they innervate things like our bowel and bladder. So if we lose function of that, then we could lose function of our elimination. Okay. So we do want to go into a little more detail because there can be questions like this in nursing. We have different function remaining depending on the location of the injury. So we're going to highlight some of the major ones that really you are expected to know and understand. First, we have the cervical level function, and we see here that the very first cervical vertebrae and C1 through C3, and in this case we're talking about basically not just the vertebrae but the spinal nerves coming off of those vertebrae. C1 through C3 results in limited movement of the head and neck. This patient will be dependent on a ventilator. They may have difficulty speaking. Now, something that we have to consider, it's not written on a slide, well, it may be, I'm not sure, but I'll mention it here. With spinal cord injuries, we talked about primary and secondary injury. When spinal cord injury occurs, the primary injury may occur at one level. However, the secondary injury extends 2 levels above and 2 levels below the injury. Okay, so just because they have a C3 injury, for example, you can think of that as going all the way up to C1 and all the way down to C5 because of the secondary injury. Okay, so let's look now specifically at C3 through C4. These patients usually have head and neck control, but they also now have the ability to shrug their shoulders. They can usually adjust to breathing without a ventilator, and they are able to speak. Okay, so just that little bit of difference coming down makes all the difference in whether or not they can move their shoulders and whether they have to be ventilated. But certainly, if you receive a patient who had a cervical injury, we are not going to base their treatment based on which one was it. No, a cervical injury is got injury to the cervical region, and there is secondary injury above and below it. So certainly we would be concerned about their respiratory status. Okay. Now C5 come down just one level, and now they have full shoulder control. They can bend their elbows. They can turn their palms face up. They can eat, drink, wash their face, brush their teeth, and shave. So all of those activities of daily living are now available to them. They can manage their own health care. They can push their own wheelchair. And they may even be set up to drive a special vehicle with special apparatus. Now, when you move to C6, what I think is so significant about this one additional level down lower is that not that they can do light housekeeping, that's always a plus, but this is big right here, the fact that they can turn in bed. They can transfer from chair to another surface with the help of some aids. But this whole mobility aspect is very important, and remember, turning themselves in bed can help them reduce the risk of pressure ulcers. So that's huge, and also they can help with their own transfer, and maybe they can use a manual wheelchair as well. Okay, at C7, now they can do all those things they could do when it was higher up at C6, but now they have the ability to straighten their elbows. Okay, so look at how important that is in terms of being able to propel your own wheelchair now that you can straighten your elbows. And they require fewer adaptive devices to help them perform all their activities of daily living. So now let's talk about the thoracic level. Let's start with the very first thoracic vertebra. If it's at this level, the patient will have strength and precision of his fingers. He can live independently without assistive devices. He can transfer from wheelchair to other surfaces. And T2 to T6, again, normal function of the head, neck, shoulders, arms, and hands and fingers. That's great. They're increasing the use of their rib and chest muscles. Before this, they didn't have use of these rib and that's intercostal and chest muscles. So now they do, and they may even have a limited walking capability. Now when we go down further to the lower thoracic area, we have added function and control. This is huge because if they have an injury in this level, that means that they have a cough. Okay? Before this, they didn't have a cough. They're paralyzed. Okay? But when they get to T7 and T12, that's why I've highlighted it here in red, because this is huge in terms of taking care of these patients and making sure that they don't develop any respiratory infections. Now they have an improved cough effectiveness. Okay? They can clear their own secretions. The leading cause of mortality in the first year following a spinal cord injury is pulmonary complications. And the primary contributors to this pulmonary complications is the fact that they have difficulty handling secretions. They can't clear their secretions. And then they develop atelectasis. And they also, with this weakened and paralyzed muscles of the chest and intercostal muscles, they have hypoventilation. Okay. As well, part of what contributes to their increase in pulmonary complications is the fact that their abdominal muscles are weak and oftentimes paralyzed. So when they do develop that effective cough, that is huge in terms of their care and preventing them from developing pulmonary complications, especially pneumonia. Vital capacity also declines in those patients who have a high paraplegia from respiratory muscle weakness. Okay, so on top of having all of the respiratory muscle weakness, we also have a decline in vital capacity, which is that volume of blood that I hope you've learned about in respiratory. This can lead to a restrictive ventilatory deficit. So they have this deficit already in terms of ventilation, in terms of the amount of oxygen and gas that is moving in and out of the lungs. With lower level injuries in the lumbar area now, we see the additional return of motor movement in the hips and the knees. So now walking can be a viable function with assistive devices. And when I say assistive devices, you can see that in this picture. Okay, these arm braces that provide support and allow them to walk. I guess that's all I had in terms of spinal cord injury. And I guess I would refer you to your textbook to see if they provide any more information. But I wanted to hit on those highlights, those major areas that we need to think about in terms of the level and the function that they may have and how that impacts their health. Okay, now we're moving to the next topic in this presentation, and that is autonomic dysreflexia. It's a very serious condition, okay, and it can cause the loss of life. It affects approximately, or I could say 90% of patients who have spinal cord injury above the T6 vertebrae. Okay, so you would need to memorize that T6, that's that magical level in which these individuals are at a high risk of developing a life-threatening condition known as autonomic dysreflexia. It is also sometimes referred to as hyperreflexia. So understand that that is the same condition. It is potentially life-threatening condition, and so it is considered an emergency, a medical emergency, and it requires immediate attention. And it occurs where the blood pressure in a person with a spinal cord injury above T6 becomes, T6 and above, becomes excessively high due to the overactivity of the autonomic nervous system. Remember, we've talked about the autonomic nervous system before. So in this picture, what you are seeing is a really nice diagram of what occurs, but I want you to know that the abbreviation SANS stands for sympathetic autonomic nervous system stimulation. And that is why we end up having this very high blood pressure. They become very hypertensive, but of course they cannot do anything about it because of the interruption in their spinal cord. The most common symptoms we'll talk about shortly are things like sweating, pounding headache, tingling sensation on the face and neck, blotchy skin around the neck, and goosebumps. Not all the symptoms always appear at once, and their severity may vary. In untreated and extreme cases of autonomic dysreflexia, this hypertension, this high blood pressure can lead to stroke and death. And I'll repeat that again later, because it is the hypertension that leads to stroke and death. So we have to treat this patient. It is caused when a painful stimulus occurs below the level of the spinal cord injury. The stimulus is then mediated through the central nervous system and the peripheral nervous system. Now, when I say painful stimulus below the level of the injury, this slide says noxious stimulus because it doesn't necessarily have to be painful. It can be just an irritation. Something as simple as a little irritation can lead to a life-threatening condition in this population of patients, such as, we say right here on the slide, an ingrown toenail. Something as little as leaving the cap of a syringe underneath the patient's left on the sheets and the patient is laying on it. Any little irritant or anything that can stimulate the nervous system can lead to this. The most common reason is a full bladder. Okay, so having a full bladder is probably the most common cause of this life-threatening condition. We did talk already about those symptoms that can present, such as sweating, headache, tingling sensations, chills. Okay, we did talk about that, but we have highlighted on this slide the most important one in terms of why a patient can have a life-threatening condition is because of the severe high blood pressure and that leading to stroke. Okay, so I highlighted this in red so you always remember that it is what's dangerous about this is the high blood pressure. Okay. Now the pathophysiology is a little too complex for me to go into now during this presentation, but I certainly would refer you to the textbook if you want a better understanding of the pathophysiology regarding the two branches of the autonomic nervous system. But I won't be testing you on the pathophysiology. However, there are nursing questions in terms of how the patient presents. But I'm not going to test you on why they present that way, but certainly I would encourage you to read a textbook if you so choose to want to understand it in that detail. And this does kind of breaks it down for you. But the patient presents in two different ways, one above the level of the injury and a completely different presentation below the level of the injury. The sympathetic response to this stimulus causes vasoconstriction, resulting in hypertension, pounding headache, visual changes, anxiety, pallor, and goosebumps below the level of the injury. Okay, so that's why you see that in the diagram. Okay, pallor and goosebumps and vasoconstriction below the level of the injury. This is different above the level of the injury. Then instead we see flushing and profuse diaphoresis above the level of the injury. So once again, it presents differently, whether it's below or above the level of injury. Below we have pale, cool skin and goosebumps, and above we have flushed skin with profuse diaphoresis. Now, most patients will experience autonomic dysreflexia, their first episode within a year of their spinal cord injury. So let me make this clear that spinal cord injury patients leave the hospital more often before they ever have their first episode of autonomic dysreflexia. Okay? Probably they're going to leave the hospital within a number of weeks, maybe, a number of weeks generally. However, their first episode is not going to occur when they're in the hospital. This occurs later. Okay, so that means that we have to educate the patient and their families and caregivers who are taking care of them about the signs and symptoms of autonomic dysreflexia, because they need to identify the first episode themselves at home. It's not uncommon for them to suffer frequent repeated episodes of autonomic dysreflexia. So please make sure you don't get confused. Autonomic dysreflexia does not occur immediately after having a spinal cord injury at the T6 level or above. So this occurs later. Now the nurse's role is not to, in the past when they used to stay there for months and months, years ago, they would experience their first episode of autonomic dysreflexia in the hospital, but not anymore. So we have to educate them so that they know what to do. And they know, frequently they'll know when they're getting another episode because they've experienced it one time at home, and then after that they really will start to have a feeling like maybe this is going to happen again. So now let's talk about common causes of autonomic dysreflexia. The common causes, we said the number one is a full bladder. Anything that would have been painful, uncomfortable, or physically irritating before the injury may cause autonomic dysreflexia after the injury. Most common cause seems to be overfilling of the bladder. And so make sure, as far as our hospitalized patient, that we don't have a kink in our Foley catheter drainage tubing. Sometimes it gets caught in the bed rail. So if that occurs, that could lead to an overfilling of the bladder in this patient. So we make sure that the Foley catheter is draining. Let's see. Make sure there's no blockage in the urinary drainage device. Another cause is bladder infection. So if the patient develops a bladder infection, this too could lead to autonomic dysreflexia. Other things included in that same category would be if they don't adequately empty their bladder, if they experience bladder spasms or possibly stones in the bladder. All of those things fall into that category. The second most common cause is a bowel that is full of stool or gas. So any stimulus to the rectum, such as a digital stimulation, can trigger a reaction leading to autonomic dysreflexia. Other causes include skin irritations. So there's a long list here. I'll read some of them for you. Wounds, pressure sores, burns, broken bones, ingrown toenails, appendicitis, and other medical complications. All of those things can. Any irritant that would ordinarily cause pain to areas of the body below the level of the spinal injury can lead to autonomic dysreflexia. Constipation, going back to a full bowel, constipation or impaction, fecal impaction. Hemorrhoids or anal fissures. Okay, so the list goes on and on. So, I mean, I couldn't possibly give you everything that could cause it. Even something as a wrinkle in the bed sheets. I love to talk about that because the littlest irritant, even a wrinkle in the bed sheet or a cap of a syringe laying on it could lead to it. But certainly other things like restrictive clothing, definitely wouldn't want to use tight belts or any restrictive clothing below the level of the injury. Oops. Oh, I want to go back. Okay. Before I talk about what's on this slide, I want to mention that because there's lots of nursing questions about autonomic dysreflexia, and you need to understand that hypertension is what makes it so lethal. So if a patient is demonstrating signs and symptoms, they've developed, first of all, in the stem of the question, you would have to have a spinal cord injury, and the spinal cord injury would have to be at T6 or above. And they start to experience symptoms of autonomic dysreflexia. You need to know the symptoms so you recognize that's what's occurring. And then you need to do something for the patient. Okay, so this is a test-taking strategy I want to repeat again to all of you. Make sure you understand if the patient is in distress, and this patient is in distress even though he only has a headache, because of what that means, it signifies that he may be developing a life-threatening medical emergency. So that patient is in distress. You must intervene. Okay, and how are you going to intervene? You're not going to say, oh, I'm going to search for the cause. I'm going to see if he has a blockage in his Foley catheter tubing. I'm going to see if it's, no, we're not searching. I'm going to search and see if his belt is too tight. No, we're not searching. The guy is going to die. Why is he going to die of? He's going to die of high blood pressures that cause a stroke. So what can we do? What position could we place the patient in that would immediately lower his blood pressure? That's how you have to think. And so certainly it's having the patient sit up. Have him dangle his feet over the side of the bed with assistance if necessary, but he's got to sit up, because when you elevate the head of the bed or have him sit up and you dangle his feet, that will cause more of the circulating blood volume to be out there, down there in the dependent extremities, and less returning to the right side of the heart, and that will decrease blood pressure. Okay, it decreases preload. So if that decreases blood pressure, that's going to decrease their risk of having a stroke. Okay, so I hope that's very clear to you. You want to select the intervention that is going to immediately or as in this case with a position change that's pretty immediate, is going to change their blood pressure. Okay, because it's all about the blood pressure here. You again later, another thing that you would want to do is certainly to administer any blood pressure medication that they have. Okay, that's also very helpful to get the blood pressure down, because you realize that that's what's going to kill them, that severe hypertension. Okay, so I just added this last slide here because I wanted you to see that they are doing lots of work and studies and research to try to come up with devices that will improve the life of spinal cord injury patients. And there are labs that are experimenting with this device called a sacral anterior root stimulator. It is surgically implanted, but the control is external to the body. And this little switch that they could use allows them to evacuate their bladder and control it themselves. Okay, remember, these people don't have control over their bladder at T6 and below. So if you don't have control of your bladder and this device works so that you could do that yourselves, that would be great. It also, which I think is fantastic, allows for bowel management. Again, with the use of the stimulator and turning the switch, you can have a scheduled bowel movement. And so while that's all very nice in terms of improving the quality of life of these individuals, and for a male patient as well, it does even allow for erections. But I didn't put that on here. Students seem to get all caught up in that fact, because it's wonderful for improving their quality of life in terms of all of those functions. But really, where the biggest benefit of this device is that it eliminates the risk of serious consequences of autonomic dysreflexia. Because what did we say is the two top main reasons is the fact that they have a full bladder, and now you don't have to have a full bladder because you can put yourself on a regular voiding schedule, and you don't have to have an impacted bowel or a constipation. You can schedule your bowel movements as well. So this really eliminates the risk of autonomic dysreflexia for this patient population. Okay.